But it's such a pleasure to be here. I'm a huge fan of Bobbie's, and so it's just a treat to get to do this and to meet all of you. So this, I'm reading an excerpt from chapter 4 of my book. This is actually one day in the hospital. It starts with me getting up in the morning, going to work, and this is about 10 in the morning. And the title of the chapter is Worries. Rapid response team comes over the PA system, and I wait, holding my breath to find out where. Medical oncology. Shit, our floor, which room? It's here, it's Mr. King. I hear Nora. She's in the pod next to mine. I walk back to her fast and see Susie coming down the hall, fast too, with Randy behind her. Nora has already pulled the crash cart into the room, and I see, quickly, Mr. King, a patient most of us have known for over 2 years, lying in bed, not moving, with a thin stream of blood running from his mouth, down his chin, onto his chest. My focus narrows to what's right in front of me. The portable defibrillator is on the bed next to Mr. King. I grab the small plastic instrument we use to measure oxygen saturation and stick his finger into it. What's his pulse ox? Asks Nora. Waiting. The machine registers a horizontal line as it calculates Mr. King's oxygen level. 75%. I'm cracking the cart, getting out a non-rebreather. That's Randy. I hear Susie say, "What happened to him?" as I wrap the blood pressure cuff around his arm and start the machine so we can get his pressure. Nora says, "I don't know. I walked in and found him like this." "Here, you can record." She shoves a clipboard at Susie. "Write down everything that happens on this form." Susie's new. Susie's eyes widen, but she takes the clipboard and clicks her pen open. Suddenly the room floods with people. An ICU doc, nurses from the ICU, a respiratory therapist, an anesthesiologist. The code team has arrived. This intensivist, Matt, is a friend. Despite not being any older than I am, he's world-weary, but also whip-smart with a well of compassion hidden beneath his hard edge. He stands by the opposite side of the bed, across from me, and our eyes briefly meet. Then he raises his voice above the loud buzz in the room. "What's up with this patient? Who's the nurse?" Nora's good in codes. She rolls the information out like she'd memorized it. Day 100 plus of a mud transplant, patient has GVH of the lungs and a fungal pneumonia with increasing needs for oxygen. Alert and oriented with occasional moments of confusion, bedbound due to weakness. Walked in this morning and saw him like that, non-responsive. O2 sat 75%, so we put him on a non-rebreather. She points to the breathing apparatus now covering Mr. King's nose and mouth. The sats now? 88% on 12 liters. 12 liters is the maximum amount of oxygen that device can give, and 88% is far below normal, which hovers between 95 and 100. Heart rate? 50, someone calls out as Matt flips through Mr. King's chart. Pressure? 100 over 80, I say. Let's get some blood gases, he tells the respiratory therapist. What's his pressure and what's his platelet count? 100 over 80, I say again, louder this time. But I'm not sure Matt hears me over the ICU nurse calling out, "We have a bed. He can go to A222. Nora also calls out at the same time. Platelets are 10. He's refractory. No HLAs available. With a platelet count of 10, people can bleed spontaneously. And although we've been transfusing him regularly, his platelet count barely rises each time. HLAs are platelets matched to Mr. King's blood, but we don't have any on hand. They can be hard to get." "Do I get to hear a blood pressure or not?" Matt demands. I look at him and raise my voice. "It's 100 over 80, I say very loudly, and he nods to himself. "Okay, we'll take that bed, pack him up and move him out. He's stable enough to transfer. We'll intubate him downstairs if we need to." "Can we take him down in your bed?" the ICU nurse asks Nora. "We've got time. We can do it for you. You'll return our defibrillator and the bed?" No, but you'll have to bring down his meds and give report. You can take them back with you then." I have a sick taste in my mouth. Mr. King was my patient when he was first diagnosed over 2 years ago. He's gone up and down, but I thought he was in an up phase. I haven't taken care of him for a while though, so he must have gotten worse without my hearing about it. Having blood drip from his mouth and pool on his chest is unsettling, since it suggests he didn't notice enough to spit or even turn his head to let it dribble out. He aspirated. It's a low murmur passed person to person. Some of the blood from Mr. King's mouth went down the wrong tube into his lungs. Has anyone called Opal, I say? His wife. She's tough and resilient, but not prepared for this turn of events, at least not the last time I talked to her. I called her, says the nurse practitioner, who's permanently on the stem cell transplant team. Mr. King is one of their patients. She can't come right away, but as soon as possible. They live more than an hour's drive away, and he's been in and out of the hospital for 2 years. God knows how she's keeping the rest of her life going in between times. Nora, Randy, and the ICU nurses gather Mr. King's things, framed pictures, extra pairs of pajamas, and put them in some of our patient belonging bags. He'll have a lot less room in the ICU. Opal will have to take some of it home, I guess. Matt has signed off on the rapid response sheet that Susie filled out and starts to walk back up the hall when I flag him down. I lean in closer to him and keep my voice low. What do you think his chances are? Slim to none, he says, like he's swearing, and I hear in his voice that note of concern masked by resignation that made me like him the first time we met. That bad? He grabs my arm. Theresa, we're all gonna die. Right, I know, but I like him, I say, trying not to sound childish. If you really like him, then wish for the family to put him on hospice so we don't have to keep all this up in the ICU. No chance that he'll make it? He stops and looks at me for a minute without speaking. We're about the same height and our eyes meet. His lungs are junk. We can't stop him from bleeding, and he's got an opportunistic infection that's barely under control. I'd forgotten about the infection, I say in a low voice, mostly talking to myself. Wish for hospice, he tells me firmly, and we both start walking again. At my pod, we wave goodbye to each other. Thanks for looking on the bright side. He gives me a pained smile then. That's what I'm here for. The ICU nurses start to roll Mr. King down the hall. A housekeeper will clean the room, making it ready for a new patient. Nora will give report to the nurse in the ICU, just like the day shift nurses all got report this morning, then come back upstairs and record everything that happened on the computer. Susie documented during the code, but that was on paper. Half an hour, 45 minutes, and the emergency is over, except it feels like Mr. King took a piece of my heart with him, and he wasn't even my patient today. Thanks.
So, Theresa, one of the things that your book captures so perfectly is that, and we got a bit of this in your reading, is this frantic pace that you experienced on an oncology floor, and I think most nurses experience in many instances. And it was relentless from the moment you get there till the moment you leave. So, can you talk a little bit about, from your experience, what you think we can do in a clinical setting to try and not alleviate that because it's part of the job, but to help nurses manage that frantic pace?
Yeah, I think a lot of the problem is when suddenly something goes haywire, there's no one who can step in and help you out. If you work on a great floor and you work with great people and they have time, that's an important caveat, then they can come and help you. So one morning I had a patient code and he couldn't go to the ICU right away, and the other nurses came and gave my morning meds and really helped me out, but they had time to do that. So I really feel like we need staff available who can come in an emergency so that you don't suddenly feel like you're drowning and someone who needs your care could really end up not doing well because you can't be there for them.
Mm-hmm. So So one of the things that we think a lot about in terms of educating our students, and one of what we think will be a major focus of the future is the whole idea about care coordination and helping individuals transition across care environments. And you talk about some of the patients transferring within the hospital, but also eventually going in and out of the hospital. So it's something that we focus on a lot. And I wonder if you could speak now from your current position in palliative and hospice care, from how you think that helps patients. We think it helps us, but how you think that helps patients.
I think it definitely helps patients because, I mean, you all know this for the patient in the room. People come in, they go out, sometimes they don't even introduce themselves. Sometimes the patient can't listen that well because they don't feel good, or, I mean, I remember we had a patient who every morning the surgical team would come and see him, and it was creating I mean, it's not funny, but it's so absurd, creating the sense of terror in him because he thought every single day he was going to have surgery because the surgical team was coming in, and it had nothing to do with, it was some very, very minor thing. I don't even remember why, but it took a while to get that straightened out. So in palliative care and hospice, it's just as important because you often get people who are very sick, and so there's their cardiologist and their pulmonologist and their primary care doctor, and it's not always clear once someone's in the home who actually has primary responsibility for them. So as the nurse, that's what I do when I go in, is try to find out who the right person is and get what I need from that person and then update them. But all the communication balls that get dropped all the time are very troubling. And I think it's great we have this role of nurse navigators, but I wish we could just let nurses be navigators. Like, you know, like I wish I could just navigate my patients. That seems ideal.
Yeah. So you talk in your book, and you talk about it in a way that, you know, you can close your eyes and see it when you're reading it. The social and organizational and relationship dynamics that go on all the time. Your entire shift, always going on. So you do interject some social things. There's a lot of different people. I love I mean, it was heartbreaking, but the part about the gurney, the patient wanting to ride the gurney. So when you think about all that going on at the same time, how can we help the other members of these teams sort of help us with these dynamics?
Yeah, I think if we could all stop and remember that we're working with other people, that sounds so obvious, but I think we start to see, well, I'm in nursing, and then so there's doctors who are kind of above me and can be helpful and can be annoying, and then there's aides and they kind of work for me, but I'm not really their supervisor, and then transporters and respiratory therapists, and we're so busy that we're so glad when there's someone else who has a function that we don't have to perform, but we forget that they're people. And in fact, I tried to come to terms with that in the book when I was writing about aides and transporters, and it was my editor who pushed me. It was after I'd had an encounter with a doctor who seemed fairly oblivious to my even being there. And then I had a transporter come to get a patient, and she said, you know, this is really the very same behavior you're exhibiting. And it went into the book because it was a really great insight for me. Like, you know, we only think of the people above us ignoring us and don't think about who we're ignoring. So I was glad she said that. I mean, you learn in kindergarten, right, to be respectful, but then when you get really, really busy and lives are on the line, you forget. You feel like that's extraneous, but it's not extraneous.
So how did you make time for relationships?
Well, if it was very, very crucial, I would give someone else my phone. That you can't do that very often. Someone will yell at you if you're doing that a lot and not answering your phone. But once I had known this family, husband had just gotten very bad news, and I just sat in the lounge with the wife, and actually had even brought her food from Starbucks because she hadn't been able to eat anything. So this is nursing, right? But other times, I just have to try and scratch it out, and the book, I'm trying to discharge someone, and my phone keeps ringing, and it's stuff that I can't ignore, and that's so frustrating. And someone was writing about this online and said it makes you wonder why she doesn't just finish the paperwork. And
she didn't finish the book.
Yeah, right. It's like, clearly this is not someone who got it, right? That you have to answer your phone, and usually it's something that matters. At least it matters a lot to the person on the other end of the phone.
So I want to, you talk in the book in a number of places, but one place in particular, the importance and the value of charting, which we sort of don't think a lot about. But as the healthcare system becomes more interested in reimbursement for performance and the need to track metrics and attend to measures, and all of that to really, the purpose is to make the health system more accountable and improving quality. But we hear a lot of people talk about the burden that places on nurses in particular, but everyone. And so the busyness that you talk about, but the taking time to do the charting correctly because it's so important. Can you just comment on this idea that in the, sort of to remove yourself from the environment for a minute and sort of think about what people are saying about the value and the importance of measuring performance and how important that is to patients, at the same time the burden that places on nurses in particular? Do you have some thoughts about that?
Yes, because I think that is incredibly important, and I completely think it's great that we're doing that. I honestly do think we need metrics, and we need data on how patients are doing, and then we need to use that in very smart ways. And what I see with electronic health records is that there are too many masters that they serve. So there's reimbursement issues, there's regulatory issues, there's hospital issues, and how we felt on the floor was just, there's always some new thing that we have to do, and nothing ever gets taken away. And I mean, for a little while I was on the committee that talked about it's not software, but you know what I mean, the health record system that we used. And CMS, Center for Medicare and Medicaid, had a new requirement that when you took down an IV bag, you had to chart the time you took it down. So you hang fluids at 10 in the morning, you take them down at 10 at night, and then you have to chart that. And it had something to do with reimbursement, and it's just the feeling of like, that is so insane. I can't believe, not that it's not important, but I can't believe I'm gonna have to be doing that when I could be doing something that actually really matters to the patient. So I don't know how we get around that, but my concern is that our documentation has become a substitute for the work. So hospice is very, very regulated now compared to how it was when it first started, and hospices are coming under a lot of scrutiny for their billing, which happened because there was a lot of fraud. And it's not that scrutiny is bad, but what I really objected to was all the scrutiny seems to go on our documentation. I felt like, why doesn't someone at least ride around with me and see what I'm doing? I find it very weird how the actual physical work seems somehow less real than what we put into the computer about it.
And just to follow up on that, and you're all probably quite aware of this, especially those of you who are in a clinical environment, one of the metrics that has been a measurement for quite some time, but I think we're still puzzling it, is this business about patient satisfaction. How satisfied is the patient with the care? And what patients can only be satisfied around is what they experience. I mean, they don't know all the backstory, right? They can only be satisfied or unsatisfied about their experience. And patients' experience is based on, cultural factors and all kinds of things, including their experience of their disease. So I've often thought about nurses working in very intense and with critically ill and dying patients. And that patient's experience, how satisfied could you be with that? What do you think about that? I mean, it's a major metric, right?
Yeah, I wrote a column for the New York Times a few years ago about this, and they provocatively titled it "Hospitals Are Not Hotels," which somewhat lost my point, which is that a lot of these metrics are important. Were things explained to you? Did you understand your care? I mean, that's a baseline. We should be doing all that stuff. But what I object to is, at the end, would you recommend this hospital to someone else? I mean, I can see how if you said, absolutely not, my room was filthy, the staff kept me up all night, every time something happened, I never knew what was going on. Yeah, you wouldn't recommend that hospital. But if it's because, no, that's where I got the diagnosis that I found out I was going to die of my cancer, and then rating it on a scale of 1 to 10, to me, I just feel like that's ludicrous. Like, it's not Club Med. So again, it's not, and the interesting thing about that column was a lot of patients actually emailed me telling me their stories and objecting very politely and appropriately, but to what I had written, with very long stories about really horrible things that had happened to them in hospitals. And I said, first of all, I'm sorry you had these terrible experiences, and I really, really agree with you that change needs to be made. I just don't think that this metric is the way to do that. And what we experienced on the floor was getting a lot of pressure for things that went on the patient satisfaction score, but they don't ask, how was it when you got your chemo? Or, things that actually have to do with people's care and saving their lives. So, yeah.
It's difficult.
Yeah, it is.
So I want to ask you, and then just really one more question, and then we're going to turn it over to you all so you can ask some questions. I want to ask you about just talk with you about your columns. So I enjoy them very much. They're always, you write about things that are happening in real time. And your last column was in response to this controversy, and I don't know if any of you followed this, the talk show, The View, and the business with the nurse who was running from, I don't know if you run for Miss America, whatever you do for Miss America. Right. She was a candidate anyway, competing. She was competing for Miss America.
That's right.
And, it raised a lot of angst in the nursing community, of course, for the comments that the folks on The View made about the business with the stethoscope and a few other things. What you did, though, which I don't know if you received a lot of email about this or not, but I want you to talk about it, was to take the position, you took it back, the conversation back to the point of nursing, and how nursing should never be seen as I'm only a nurse, which the contestant talked about. But you you talked about sort of the elevating of the profession. Why did you decide to write that column? And did you get any? What kind of feedback did you get? Did any of you read that? Do you know about the column? Yeah. I see.
So it was on Slate. I can tell you that it got 22,000 it was. it was huge. I mean, I don't want that to sound like I'm bragging, but it was very gratifying because they really wanted it, and then it ended up becoming a big deal, and then they featured it more, and so it was just incredibly satisfying. So the truth of why I wrote it is, I don't watch a lot of TV, and someone alerted me to what was going on. They're like, you should really pay attention to this, Theresa. And then I started thinking about it, and I thought, yeah, I do want to say something about this, but not just to express outrage that the women of The View are snarky and ignorant about nursing, because
they are.
Right, that doesn't... I'm not sure that will advance a conversation I'm really interested in, yeah. But it was that when Joy Behar said, and why is she wearing about Miss Colorado, Kelly Johnson, why is she wearing a doctor's stethoscope? That's just what made me see red, and this whole idea that we're just always part of doctors or an appendage of doctors. And a lot of the doctors who write, some of them, like Pauline Chen, is very thoughtful about nurses and writes about nursing, and some of them, I won't name names, never talk about nurses, or it's like the nurses are the person who tucks you into your hotel room, and that's all we do. And I hate that. I hate having a doctor write about hospital care, and it's never about nurses ever. I mean, does anyone realize how stupid that is? Anyway, so yeah. So I thought this is an opportunity to say, well, here's what we do in the hospital.